My name is Eleanor Revore. I'm the Vice President for Clinical Administration and Professional Practice and the Chief Nursing Executive at Kingston General Hospital. And it is my pleasure to be working with Leslie Flynn this afternoon, who is going to be focusing on interprofessional education, which is one of those pillars upon which we believe that we will all transform the patient experience. The process this afternoon is going to be that Leslie is going to do about a 25-minute presentation just to give the context and understanding for interprofessional education, and then we're turning the work over to you, much the way you experienced this morning. And there are 4 questions that we are going to ask you to work at your tables to formulate your answers based on your experiences. And then there'll be about 35 minutes or so for you to work through that discussion and answer all 4 questions. And then we'll begin to get the feedback from the tables. And it'll profile some of the high points to each of the questions. And we will be sharing it very briefly in the next break with Andre Picard, who is going to facilitate the larger panel discussion where we hear about the 3 different themes and their influence on patient experience. So the really key part of these sessions is that knowledge and the knowledge exchange. So we hope that you've selected this either because you know you've got an experience to share that's going to be of benefit to others, or that you're coming to learn about what the opportunities are, or it can be a bit of both. So we're just very grateful that you're here. So without any further delay, I'm going to introduce Dr. Leslie Flynn, who is on faculty at Queen's University and is one of our key partners in terms of interprofessional education. She has been a member of the steering committee looking at interprofessional education at Kingston General Hospital, but is that collaboration between the 2 organizations that's been critical in terms of saying how do we support learner and new provider education, and then the transition into a clinical setting. Dr. Flynn, apart from all of her clinical expertise, is very much an expert on education. She's received departmental awards for excellent leadership in education and the annual Staff Excellence in Teaching Award. She's conducted research in physician health, the role of health advocate, interprofessional education, and the scholarship of teaching and learning. And she's presently a clinician educator with the Royal College of Physicians and Surgeons of Canada. Her position and the role that she brings in our partnership at KGH is as the Interim Vice Dean Education at the Faculty of Health Sciences. So please join me in welcoming Dr. Leslie Flynn.
Thank you very much to Eleanor and to all of you for joining me here this afternoon. As Eleanor has said, we're going to put you to work. I'm going to give you a little bit of background, what I know about interprofessional education, and then we're going to put you to work because this is a knowledge exchange. We have some hopes for you in terms of when you leave this session. We're hoping that at the end you'll commit to implementing the principles of interprofessional education in your organization. And we hope that you'll be a champion of the benefits of interprofessional education. Again, that you'll take it home to your organization. So those are fairly lofty goals, but let's get at it. Let's start with what is interprofessional education. And I put IPE because it's much easier to say IPE than interprofessional education. Interprofessional education. So what is it? This is a definition that is widely used internationally. It came from CAPE, which is the Center for Advancement of Interprofessional Education. That's an organization in the United Kingdom. And the definition of interprofessional education is those occasions when members or students of 2 or more professions learn with, from, and about one another to improve collaboration and quality of care. The Center for Advancement of Interprofessional Education is not new. It was established in 1987. The original definition, which was established in 2002, did not have the "or students." That was in 2006. They recognized that IPE is not just about the members of the profession, but it's also the students who are coming into the profession. And so it was updated, and this is an international definition. with, from, and about. If you take anything away from this session, what I'd like you to do is take with, from, and about away. That's what IPE is. If you think about what e-patient Dave said to us this morning, he said, you're going to be really successful if you can put your theme or your idea in one or two simple words that are single syllables. And this is how I remember. What is IPE? It's with, from, and about each other. So, it's important to make a distinction. A very important distinction is multi-professional education or multidisciplinary education. And that's when occasions when members or students of two or more professions learn side by side. So I challenge you to think for a moment, what are you doing right here, right now? IPE or multi-professional education?
IPE.
Pardon me?
IPE.
IPE. Are you learning, as you're sitting there now, are you learning with, from, and about each other? Or are you learning side by side?
Side by side.
Right at this moment, and so I'm not talking about the whole conference, but at this moment, you're sitting as my audience, learning side by side. And the important distinction is because, as a group of people said in 1999, Miller and her colleagues said, shared listening will not, in our view, lead to interprofessional learning nor interprofessional caring. So putting lots of professional students or professionals in a room together to listen to someone doesn't lead to interprofessional care. That's the important point. So what does IPE demand? It demands an interactive element in the learning experience. And at this moment, I'm not asking you to be interactive. So that's an important distinction to keep in your mind. I put this photo up because this is a good example of an IPE event that's happened at Queen's University in the Faculty of Health Sciences just in the fall of 2012. We have nursing students in that audience, we have OT students, and we have medicine. So nursing, medicine, and OT, and if you can capture the sense of the learning, they're all turning, they're engaged with each other. This is not multi-professional, this is interprofessional education of a group of young to-be professionals. What is interprofessional education? It is the process by which we educate health professionals to work collaboratively. It changes how healthcare providers view themselves. We know as educators that it's a complex process. It's a complex process and it requires us to look at how we deliver education in a different fashion. And what is one of the goals? It's to prepare healthcare providers to practice in a way that allows and accepts that we share skills and we share knowledge. So that's the backdrop of what's leading us to interprofessional education. So, why IPE? As I said earlier to the group that was here, if I'm a little bit cynical, I would say, well, it's been mandated. We have to do it, right? The World Health Organization has put out a 2010 call for action position paper that internationally we need to be teaching our professional learners together. We know that Health Canada did the same. Health Canada in 2003 mandated that we should be teaching our health professionals together. So that's a pretty cynical view, although it's been on everyone's radar for a long time. But I would say, and I would say from the tenor in this conference with some confidence, that this is not the only reason we're doing interprofessional education. We're doing interprofessional education because we on the ground who are involved in healthcare want to provide healthcare in a fashion that's different from a traditional fashion. We're on the ground. We want to deliver collaborative, patient and family-centered care. And that's, I think, why it's really growing now, momentum, because this isn't new. The World Health Organization started recommending interprofessional education a long time ago. Anybody in the room know how long ago the World Health Organization said we should be teaching our learners together? 1974? Good guess. Quite a while ago. 50 years ago. The first time the World Health Organization said we should be teaching our students together is 50 years old. It was in 2003 that Health Canada said, oh yes, we should be teaching our learners together. And then in 2010, the World Health Organization had to put out another action paper and say, let's get going. So I think we're now moving because the people on the ground are actually interested in moving. So, interprofessional education, why are we doing it? Not simply because it's mandated, but because we are interested in providing collaborative care and we're interested in improving collaboration. Why? Because we think if we focus on interprofessional education, we will lead to collaborative practice. That's the goal. This is a cartoon from the Canadian International Health Collaboration. This was established by Health Canada in the early 2000s. What the joke says, so you can see there's, and we had a guest come from U of T recently, and she said, this reminds me of University Avenue with all of the institutions up and down. So there's a hospital here, but then the nurses are over here, the physios are here, and pharmacy is down the road. And the caption is, how can they work together if they don't learn together? We maintain our silos or our buildings if we don't learn together. So, this is a really substantial development. In 2011, 6 professions and 8 different organizations supported those professions in declaring that in order to be an accredited educational body, you will have to implement interprofessional education into your curriculum. So you can't see them all, but there's medicine, undergrad medicine, postgrad medicine. So our medical students and our residents. There's physiotherapy, social work, nursing, occupational therapy, and pharmacy. 6 different professions have said, we will only accredit your undergrad or your program if you are teaching in an interprofessional fashion. So we're really rolling now. But it's not simply to improve collaboration. Why do IPE? We want to improve collaboration because we want to enhance the quality of care. This figure is from that 2010 action paper that I referred to. And what it says, it's the health and education systems are intimately involved, and you can't separate them. So they talk about your health needs, you educate your future health professionals, it leads to collaborative practice, which leads to improved health outcomes. And there is good evidence internationally that that is the case. Quality of care has been demonstrated to be improved with collaborative practice. It improves access to and coordination of health services. It improves outcomes for people who have chronic disease. It improves patient care and safety, and we've heard that several times in this conference already. It decreases the length of hospital stays. It decreases patient complications. It decreases staff turnover. Think about for the people who are working in the organization. It enhances recruitment and retention. It increases our satisfaction in doing the work. It decreases hospital admission, decreases clinical error, it decreases mortality rates, and it decreases conflict between the care providers. It's a happier place to work for us, as well as a safer and healthier place for our patients. And this evidence is really close to my heart because I practice psychiatry. This is about mental health collaboration. It has been well demonstrated that collaborative care increases patient and family satisfaction, promotes greater acceptance of treatment, it reduces the cost of care, most significantly it reduces the incidence of suicide, and it reduces our outpatient visits. We've got a healthier population if we deliver interprofessional collaborative care. So that's why we're doing IPE. In a nutshell, to sort of synthesize all of that, IPE enables effective collaborative practice. Collaborative practice strengthens health systems, and it improves health outcomes. So how does that work? Hugh Barr and his colleagues in the United Kingdom, he put forward this model in 1998. And I realize you're not going to be able to read it, so I'm going to walk us through the model. He put this into publication in 1998. He said that effective interprofessional education leads to a positive interaction, mutual trust and support, collaboration between professions, and it limits demands on any one profession. Therefore, we have a reduced stress level as healthcare providers. It enhances job satisfaction, which leads to improved recruitment and retention. It benefits workers. It improves client care. Hence, you get better partnership for health. He called it a chain reaction. He said IPE works as a chain reaction. Unfortunately, he's wrong. And he was the first person to actually write that, you know what? Although all of those elements can be there from IPE, but it actually isn't a little simple chain reaction. It's actually much more complicated than that. IPE is much more complicated than that. There are three foci. We know that we have to prepare the individuals to work in interprofessional collaborative care. So that is the role that our higher education institutions and organizations are providing. So our nursing schools, our medical schools, our colleges, they're preparing the individual by giving them the knowledge, the skills, and the appropriate attitudes. That's essential. We know that our health care organizations are working at IPE to improve services and delivery of care. And I would say this conference is a perfect example of the organizations working to spread the word on collaborative care. But there's this third piece, this cultivating collaboration, which is somewhere between where we start with our learners, and then how we get far down the road where we are today. Because most of the people in the room, well, let me ask the question, how many people in the room were educated in an interprofessional education fashion? I'd like to see a show of, I see 2 hands, 3, and half a hand. 3. So there's a gap between what we're teaching our learners now to expect and what our organizations, our service providers are expecting, and how are we actually doing that, cultivating the collaboration. The reason, and what I'm saying is I think there's a gap, and it's our role to bridge that gap. And I'm going to go back, because I think I can highlight where the gap lies. I'm going to go back to this model that the World Health Organization gave us. And they obviously didn't draw this to support my point, but when I look at this, I go, where is the gap? The gap is right here. Here's interprofessional education at all of our schools, and we're working hard to do it. Here's collaborative practice where our health organizations are expecting us to do it. And they've got this little wee thin line saying, hopefully there'll be something across. And that gap is what we have to fill. Because there's good evidence that it's the teachers and the supervisors of our learners as they come into our clinical care settings, and our new professionals who are joining our organizations. It's the teachers. It's the teacher characteristics which are identified as the key determination of how that educational process will actually be implemented and what the healthcare outcomes will be. The quality of the supervision in the clinical situation has been identified as the most important contribution to IPE. That's us. That's us working in our healthcare organizations, in our clinical settings, taking our learners, taking our new professionals, and ensuring that they're educated in a manner that will deliver the quality of care and collaborative care that we're thinking about. And this is another study that demonstrates these two people in the UK actually followed many of the learners who went into ward placements in the hospital. And they said facilitation really ranged from really engaging the students into interprofessional care through to very minimal output. And they were very disappointed to say that in fact most of our learners with their supervisors, with their preceptors, continue to work in silos. They work, maybe not silos up and down, they work in parallel to each other. So the nursing students are here, the physio students are here, the pharmacy students are here. They're all doing good work, but they're working in parallel. They're not working in teams. So this has been identified as the most valuable opportunity that we need to take advantage of, because we're the role models for interprofessional education and practice. So to summarize and bring it to a close so that you can get thinking about this yourself, the principles of interprofessional education are that it works to improve the quality of care, it focuses on the needs of patients and families, it involves patients and families. Now those two principles are very important. I didn't emphasize them because I knew you were hearing them in other audiences. It promotes interprofessional collaboration. IPE encourages professions to learn with, from, and about one another. It enhances practice within professions. It respects the integrity and the contribution of each one of our professionals. And the bonus is it increases our professional satisfaction, our joy in our work. So as we put you to work now, I want you to think about what are the challenges? How does an organization support IPE? And then I want to bring it closer to home and say, how does your organization support IPE? And finally, I'm putting it right in front of you, how do you support IPE? And with that introduction to what interprofessional education is, the potential benefits of IPE, we're going to give you the opportunity to have interprofessional education, where you will learn with, from, and about each other. Okay.
Thank you so much. So it's a great sort of setting of context for what IPE is, and we are going to put you to work now. On each of your tables, there is a workbook, and it has 4 questions in it, and these are the questions that we want you to focus on for about the next 35 minutes or so. Very specifically, we are asking you to consider what you like about the principles of IPE. We want you to think about those instances where you've had a very positive experience, either as a learner or as a practitioner or as an educator. The next question will be looking at what do you see to be the challenges? What have you experienced to be the challenges, or what are the things that are sort of holding back in terms of moving forward with what you would want to be doing with IPE? And then the last is, what are the strategies that you have worked with or seen put in place where it's being successfully managed? And we will have you work on that, and then I'll give you about a 5-minute cue, and I'm going to ask the reporter, in the workbook, we want you to make your notes to each of those questions, and then as a table, look at what are the top 2 of the things that you would like to bring out at a reporting back. And we'll go around the room, and if you hear a report on something that you've put on your list, we're going to ask you to move to another issue. So we don't want to repeat the issues. We want to get the full, sort of as much input and different thoughts in this. And then we will be sharing this back with the panel and Andre Picard, who's going to facilitate the synthesis panel. And then that's going to launch us into the discussion later this afternoon. So it is your intelligence and your inquiry and your voices that are going to be very key for this next part. So I just invite you to begin to work at your tables. The one thing we learned this morning is if you have collected in a table that is from your own organization, mix it up a little bit, so that you also have that opportunity in the spirit of interprofessional education to learn from individuals from other organizations as well as other groups. But you'll know by your own makeup whether that's comfortable to you or not. Okay? So enjoy and use those voices.
I've been working for just
achieved or finishing their projects because they need our help.
An individual describing the situation.
original IPE learners from the ground up to look at the ways.
Interprofessional web designer wrote that.
We didn't tend to sometimes subconsciously eliminate.
I want you to highlight the one that you just say, you've got to hear, this is what we've been doing. So we'll start with this table.
We had a really great experience with a program called More OB, and it's where all sorts of different team members come together, obstetrics, anesthesia, nurses, and family physicians, and we all take turns playing different individuals' roles, working towards a common goal of a situation that they give us, a clinical situation, and that really helps us understand where each individual is coming from.
In one hospital, they're working on having allied health do case presentations on kind of complex cases each month, and all different staff attend that, and it's an opportunity to just learn from other people about what works and what doesn't work, and it's, I guess, trying to help collaborate on maybe future cases. So that sounded like an interesting opportunity.
Becoming an anesthesia assistant is open to both nursing and respiratory therapy, and so the outcome being that we two professions have come together to create a third profession, and so therefore it's very multidisciplined and interprofessional in the sense that you have one profession with varying experiences and works together.
A specific group decided they would get together once a month for dinner. Yes, physicians and their recovered patients. And so they would have dinner and talk about, my understanding is they talk about, you know, what's happening in their experiences and share together in that informal setting. And isn't that fantastic?
We just, Critical Care, just participated in the Sim Olympics, and so that included the RTs, RNs, and physicians all working together to participate in a simulation lab and learn how to work together and compete against other teams that included a variety of interdisciplinary members, and on a fun way, and it wasn't just for KGH, but it included teams from McGill University, Ottawa U, Western had a team, I believe Oshawa did as well. So there were 20 teams participating. So Critical Care had 4 teams in place, and also included some race nurses as well that participated in with some of the medicine teams that also entered in the competition. And the Critical Care team won 3rd place this year.
When we were preparing to get ready for electronic documentation, and we sat a group of an interprofessional team down to prepare some standards or wording around how we would develop this tool, and we came to the realization very quickly that all of the interprofessional members, although we thought we were speaking the same language, when it came to try and write that down, we were speaking very different things, and nurses don't say things that way, or a pharmacist would say something different. They're thinking product, they're not thinking about that. And so coming to the realization that we need a common language as we go forward.
There's a gentleman who was a 58-year-old homeless patient with no status, so didn't qualify for CCAC, didn't qualify for rehab. But he did end up with a complication where he required to be in hospital for IV antibiotics, and because he didn't qualify for CCAC, we couldn't discharge him home on antibiotics. So during the course of that therapy, we also did physiotherapy with the whole team. We consulted a rehab facility from the AMP program to give us more instruction and give the patient instruction, so that the whole team, OT, PT, nursing, PCAs, could work with him while he was getting the last bit of his antibiotic treatment so that he could be discharged or be ready for discharge. We also collaborated with a number of different areas and organizations and units to purchase him a prosthetic, so that though he was homeless, at least he had an opportunity to be able to be discharged. So it was a very collaborative among all practitioners, different areas of the hospital. We got him into short-term rehab even though he didn't qualify within the organization. And it was a successful story.
Program and policy, and things just did not jive. It's just, the outcomes were not what we thought would be. And then we stepped back and did a second look at it, and this time we involved, we sought input from many clinical areas and support services as well, and used that input into developing the new process and procedure.
I provided an example of an educational initiative going on at the facility where I work, and we are bringing more than just professional groups together. We're bringing all of our hospital staff together, so maintenance, housekeeping, dietary are an active, which is a challenge for IPE, but I think we might be surpassing it by involving everyone that works at our hospital for our quality and patient safety risk education that's mandatory. So we have a maintenance manager speaking to everyone. We have the whole staff watching a terminal clean of a housekeeper. We have them learning about the VTE protocol. So everyone's involved on a level that's probably even better than interprofessional, but rather everyone. So it's really effective, and the feedback is phenomenal. It's engaging, it's collaborative, it's all those things that it makes everyone feel like they're part of the team, and it's been successful for a few years.
It really links to, I think, the comment at the table about what's professional. Like,
it almost feels like a shortfall by interprofessional, rather, hospital worker.
The community showcase that that you did in January at KGH, which involved the entire organization to a degree, with job shadowing and town or open houses and the booths and all that.
We mentioned the patient family feedback forums as just an opportunity to have non-judgmental discussions about what works, what didn't work for patients or their families.
The example that we thought we'd share is at the Center for Addiction and Mental Health, we're rolling out some curriculum. We're creating curriculum to support the adoption of some best practice initiatives. And the way that we worked on the curriculum is we brought together patients, family, peers, ethics, psychiatrists, education, curriculum developers to work on the project together.
So we mentioned students and how in some placements within organizations we're allowing students to go to different areas within the hospital. So for example, the example that was given was a nursing student to go and spend some time in scheduling or go and spend some time in pharmacy or DI to be able to see the full scope of how each practice works, to bring it together.
At Hamilton, we offer, it's called Gentle Persuasive Approaches Education in our acute care setting, and it's truly an interprofessional environment. It's actually, so all members are the team. It's education that supports staff in de-escalating sort of situations where patients with responsive behavior related to dementia. So everyone from our physios, OTs, nursing, physicians are invited, porters, EAs, everyone. Security are actually part of our coaching team. Our staff coaches are, we have a security supervisor who's one of the coaches. So it truly is interprofessional, and it absolutely is very reflective of the environment to say it takes an entire team to be able to support a patient and family in sort of that circumstance. So it's been very effective.
Sometimes it's scarce staffing areas so people can go and meet. Okay. Yeah, for the interprofessional meetings. Another one is having administration buy-in.
We looked at information technology and the challenges with that among all the different professionals, and how even though we work together, our information, how we report it or how we collect it still tends to be in silos, and what our focus is still in silos. And we talked a bit about how our new charting at the hospital does have people charting together, and although there's some unity with the collection of data together day by day, that in itself does create some problems for people who may be looking, for example, at a consult that respirology may have had, and then respirology is follow up, and then you have to kind of go through, if there's one specific area you're looking at, you still have to go searching through that. So there are some struggles as far as grouping the data together, but then trying to pick out of that as well. So.
We felt that egos could be an issue with, they've never worked together, so wherever everybody is in their own sort of process, there could still be a stumbling block there.